lucky today because we have Dr. Karen Anderson, and she came to us all the way from Georgetown University. She is a psychiatrist, and she also runs the Center of Excellence over in Georgetown, and it's the university. Georgetown University. And if you actually look at the Huntington Study Group and you see anything about psychiatry where they have found, data, they've actually figured out things that we need as a community, Karen Anderson's name is on it. So she is huge. She's very special. We are so thankful that she came all this way to talk to us about managing psychiatric symptoms in HD.
Well, good morning. Thank you all for getting up early and having early breakfast and maybe communing with the sea lions a little bit this morning. I know I did, and they were very lovely. So I'm going to talk to you about behavioral symptoms in HD. And just a couple of disclosures. So I've done work with several of the companies that are here. I don't think that any of them have a direct impact on my talk today. So I'm going to do a general overview of behavioral symptoms, sort of helping you think about them, think about what to report to your doctors when you go into clinic, how to ask for help, because I think that's often the starting point, right, is to know how to tell your health professionals what's going on so that they can help you. Because sometimes you kind of have to use their language because they don't really understand what you're saying, which is unfortunate. So a couple things first about environment, because I think big picture is we always need to think about the environment where somebody with HD is. There are a lot of things going on in the environment that can contribute to symptoms. And particularly with psychiatric symptoms, environmental factors can actually make them worse. So what do I mean? For example, hunger or thirst. Think about the times when you haven't been able to get to lunch because you've been so busy doing something, or think about the times when you're out at an event and there's no water around and you're very thirsty. It makes anybody more irritable, it makes anybody angry. So all of these things, if you don't stay hydrated, you don't have good nutrition, that can actually make a lot of these psychiatric symptoms worse. Certainly frustration due to communication issues can bring out psychiatric symptoms. So someone who's generally pretty reasonable, pretty willing to tell you what's going on, but they can't talk and you can't understand them, that frustration can actually bring out quite a bit of irritability and aggression, which are a couple things I'm going to talk about today. Sleep issues, we all know we're not at our best when we haven't had a good night of sleep. It may be that someone's uncomfortable, maybe their bed doesn't have enough cushioning, maybe there are other reasons why they can't sleep well, so getting those problems corrected can really help a lot. Boredom. So does somebody have an environment where there's just not enough going on, they're not stimulated enough? Or the opposite problem, are they in an environment where there are grandkids running in and out, there's a TV on all the time, and it's just too much noise and stimulation, and it's getting the person too revved up and it's not good. So these are all individualized things. The cold room that makes me happy would make someone else very unhappy in terms of sleeping. The snack schedule that I like is not going to be your snack schedule. These are all very individualized but important to think about. So, anybody with HD can get any of the psychiatric symptoms that the rest of us get, right? There are just some that are a bit more common in HD, so I'll talk a little bit about some of those. And certainly we all know in this room that behavioral symptoms are one of the most burdensome parts of HD. They often lead to emergency room visits, they can lead to placement in long-term care, long before somebody really needs to be in long-term care. So the goal of this talk is to convince you that you should report these symptoms and ask for help and treatment, because it really will improve everything for the patient, because nobody enjoys having these symptoms, and also for your entire family. So we're going to focus on a few of them because I don't have time to talk about all of them. I would love to come back another time and focus on some of the others. But I'll talk about mood disorders, suicide, which is such an important topic, anxiety, psychotic disorders, so delusions and hallucinations, and then I'll finish up with irritability and aggression. So a lot to go through in a few minutes, and I'm happy to answer questions on our HIPE panel if there are things I don't get to. So in terms of progression of behavioral symptoms, we did some work with the European HD Network, which has fabulous psychiatrists in their group, and we really found that if you look here on blue, my pointer's not going to work. If you look at the blue bars up there, it really shows you that apathy, which is lack of motivation, tends to get worse throughout the disease. Irritability and aggression, depression, They also tend to get worse, but they can all be seen across all stages of HD. So important to realize that the symptoms can really start in early stages. I don't have pre-symptomatic on there, but even pre-symptomatic, you can see some of these symptoms. So we do have guidelines out that are free and available. So I just put these up here because I want you to be aware that any of you can go online. They're on the Journal of Huntington's Disease. So if you just Google Journal of Huntington's Disease and my name, I'm the lead author, you can pull up these guidelines that we wrote for treatment. These are on different symptoms, so agitation, anxiety, apathy, psychosis, and sleep disorders. And so they've got some really good recommendations that you can print out and look at yourself, and then also take to your doctor if he or she is not so familiar with HD as sort of a starting point for these. So keep those in mind. So I'm going to start out talking about depression. So depression is incredibly common in the general population, right? So many people have depression, even more common in Huntington's. So depending on how you ask about depression and what your cutoff is for saying somebody is depressed, about 50% of people with HD have depression. Some studies have found to be up to 80%, so really common. So we talked about environment already, but just to review it again, sleep disorders, those are one of the biggest things that we see impacting mood in a very negative way if somebody has sleep trouble due to HD. Certainly losses, so someone comes into clinic and patient and the family have this conversation about how driving is no longer a good idea. Maybe it's time to stop working, and that would make any of us feel depressed, right? So a lot of losses, death of an affected family member, so the anniversary of when a family member who had HD died. Participation in a treatment study ending, it's one that we don't talk about enough, but we've had these fabulous high-tech studies that get all these flashy headlines, which is wonderful. And it's wonderful that we have the pharmaceutical companies invested in HD, but when a study stops, when it's maybe stopped abruptly, or it just comes to an end because it's the end of the study, sometimes it's very hard for patients. They feel like they've been part of something, they feel like it's been so hopeful, and then it all ends. And it's not necessarily, there's not necessarily good follow-up after that. So they've been part of something and then it's done. So really important to think about, if your family member's in a treatment study, maybe you want to try to, make sure he or she gets into clinic to see the usual doctors when the study ends. And then there are some medications that can affect mood also, and we can talk about those during the HIPE panel maybe. So certainly in terms of treatment of depression, the good news is treatment of depression and Huntington's is pretty much what you do in the general population. So if you go to your doctor with depression and the doctor says, I can't treat Huntington's, you can say, well, you treat depression in the general population, so you can find an antidepressant for me. So that's sort of the starting point in this. If somebody's in a more advanced stage, or if they're very frail and older, you might start with a lower dose, and that's sort of common sense. Most good, primary care docs understand that. Sometimes you do need to go to higher doses, and you do that slowly. And then don't forget about therapy. So particularly for people who are early on in the disease, maybe dealing with some of the losses I talked about, a referral for supportive therapy with a social worker, with a psychologist can be incredibly helpful. So don't forget about that. So just a quick word on suicide, because it is such a problem. Suicide rates are reported to be up to 4 times the general population in HD, so a high risk of people completing suicide, meaning they take their own lives. There are some risk factors that we know about out there in the general population, such as not having children, drug abuse, access to weapons, particularly handguns and rifles. But often in people with HD, it's unpredictable, and they choose methods that are very high risk. So, it's not someone taking a paperclip and scratching their wrist a couple times, it's somebody driving their truck off a cliff. I mean, it's really very dramatic and it's very unfortunate. So it's not always tied to depressed mood. That's really hard, because if you go into the emergency room with your loved one who's thinking about suicide, there may not necessarily be depression or sadness, and the people in the emergency room may not understand that. They may not take it seriously. It's also because of the high suicide rates, it may be more acceptable for some people. There are some studies in the general population that if you have a relative who's taken his or her own life, you're more likely to do that because you see it as sort of an acceptable option. So some of the things I've seen over the years of why people tried to kill themselves, some of them can seem kind of minor. So someone who was mad at her husband, he wouldn't buy more cigarettes because she wanted so many and their budget didn't allow for it. So she walked out the door and into a major intersection in Baltimore. The anniversary reaction, so it's the day that your father killed himself by jumping off a bridge and you decided that you couldn't stop thinking about it and it was time for you. Thinking about the future, so seeing how a parent ended up not wanting to go down that path and thinking about when it would be time to do that, and then getting genetic test results. So someone goes in and finds out they have the HD expansion. So these are all stories that you hear about. So, you know, a lot of diversity in terms of why people think about suicide in HD. This is a study that Jane Paulson did a few years ago, and I don't want you to get too hung up on the amount of data on the slide, but just to note, so if this is thinking about suicide, this is not actually attempting suicide, but people tend to think about suicide more right around the time of possible HD. So maybe when they start to drop things more, when the doctor says, you know, you do have a little bit of movement there, we should keep an eye on this. And then in terms of disease stage, so again in stage 2, where people start to lose things, they start losing driving, taking care of their kids, working. So those are times to be particularly worried and vigilant about suicide. Now I'm going to go on to anxiety. So anxiety is, again, really prevalent. Up to 50% of people with HD have anxiety, you know, worrying about things, you know, being overly worked up. Small things can sort of cause anxiety throughout the entire day. It often goes with depression in Huntington's, just like in the general population. And of course, if you have memory loss, that can actually make anxiety worse because you actually can't remember, so you worry about something even though you have the answer. We don't have any good trials, but we know that antidepressants, which are also approved for anxiety in many cases, are actually really helpful. So again, it's good to tell your doctor about this and get treatment. There are some other medicines like benzodiazepines, which we might need to use occasionally, and maybe antipsychotics. So these are things to keep in mind. They are in the treatment guidelines if any of you have questions about this. So now I'll go on to psychotic disorders. So these are things like hallucinations, beliefs that people are against you, paranoia, or hallucinations of seeing things, hearing things that aren't there, smelling things, even feeling things. So usually they're seen in later stage patients, often people who are in long-term care, but it can be seen at any stage of disease. Older work probably confused schizophrenia, so people with a diagnosis of schizophrenia with Huntington's, because everyone was sort of put in the big state hospitals together. They didn't have genetic testing, so it wasn't always clear what somebody's diagnosis was. Usually in HD, the delusions are not so complex. So in HD, people might say things like, my food is poisoned, my spouse is having an affair, as opposed to schizophrenia, where you get these really interesting ideas that the FBI is monitoring me and I should wear tinfoil on my head because of the satellite waves that are coming into me. So sort of a different flavor. It can be really difficult to know, of course, if somebody has dysarthria, so if their speech is really impaired. Very hard to know if they really have a delusion because you can't understand what they're saying, but they may still be struggling with this. So we have clinical practice guidelines on this, and the really key thing on this slide, I know it's a lot of words, is to look at other medical conditions. So if someone has an infection, if someone's had a recent fall and a bleed into their brain, if they suddenly have a delusion out of nowhere, it's important to get to your primary care doc and just make sure there's nothing else going on. And then there are antipsychotic drugs that we use that are very good for treating delusions, hallucinations, but you have to tell your doctor about that. So they are out there. So now a couple words on irritability and aggression. So these are two of the most common things that I'm asked to work on as a psychiatrist in our HD clinic. Again, really common, up to 80% of people have irritability. So irritability is reduced control of temper. Small things irritate you more than they should. You can be irritable without people knowing it, although I find that hard to imagine because when I'm irritable, my whole house knows that I'm really irritable. But irritability is always unpleasant. So people don't go around saying that they're, happy to be irritable and feel like everyone's on their case all the time. And a typical thing that I will hear from a patient who's brought in to see me because of irritability is that everyone else bothers me all the time. So they don't necessarily see that they have something going on. They feel like the whole family is always bothering them and asking them things and wanting them to do things they don't want to do, for example. It's challenging to treat because so many of the medications that help irritability also make people sleepy or worsen fall risk, and also can worsen cognitive issues. So the types of things that you might think about, like a benzodiazepine, like Klonopin, which can sort of calm someone down, might also make them more likely to fall. The other unfortunate thing is that sometimes people end up on multiple drugs to treat irritability, and then you get a compounding of all the side effects of all the drugs together, and it sort of gets worse. So we did a survey a few years ago looking at experts and how they would treat irritability in HD, and we found that SSRI antidepressants, so good old, Prozac, Paxil, Zoloft, the things that we think about, are usually the first line of treatment, and that's good because those tend not to have so many side effects. And then antipsychotics, so maybe haloperidol, risperidone, olanzapine, are also used, or mood stabilizers, so something like Depakote. And then, in addition, so you might have your first choice, which is here in blue. Then there were alternatives, so if the first one didn't work, you might go to a second one. So if the SSRI that I tried doesn't work, I might go to an antipsychotic, depending on how severe the symptoms are. And then we have what's called adjunctive. So sometimes we do add a second medicine in. If I've gotten a partial response, but it's not great, I might add a second medication. So just to let you know how I think about treatment. And now aggression. So aggression is sort of irritability's ugly sister, right? So this is when the inward behavior comes out and it gets forceful, it's hostile, it's always the intent to harm something or someone. Sometimes it occurs in retaliation. So you tried to change my shirt, I got cold and I'm mad at you, so now I'm gonna hit you. Often it's not any cause at all that people just strike out for no reason. It can be verbal, so cussing someone out. It can be property damage, so hitting a hole in the wall with your cane, or it can be assaulting people and pets directly. So the treatment, again, antidepressants. So if the aggression is not so severe that people's lives are in danger, an antidepressant, again, good old Zoloft, good old Paxil will probably do the job. The antipsychotics can be really helpful, so risperidone, or particularly olanzapine, which can be more sedating. The mood stabilizers like Depakote, and then occasionally the benzodiazepines, although I have to say the medicines like clonazepam, sometimes they calm people down, but sometimes if someone's aggressive, it actually makes them disinhibited. So it's kind of like having an angry drunk, so it's not a good option in some cases. So in summary, I know that you all understand the huge impact of behavioral symptoms, but the message is that there are treatments available. We have these free treatment guidelines out there. So tell your doctor. I've given you a few words of language to use, in terms of how clinicians think about these symptoms, to tell your doctor. So sometimes just communicating to the doctor and getting him or her to understand what's going on is the biggest challenge. And we don't have we've got expert guidance, which I mentioned. We don't have a lot of clinical trials yet, although we are working on those for behavioral symptoms. So thank you very much, and I'll be happy to take questions later at the HIPE panel.
So the goals of this session are to describe how the brain changes that we see with Huntington's can lead to some of the difficulties with thinking, and of course thinking affects behavior, so we overlap a little bit with Dr. Anderson's topic. She focused more on the mood aspects, but we're going to talk about memory and other sorts of difficulties that can happen. Okay, I want to acknowledge this wonderful resource. This is actually a book that's been in print for about, maybe this might be the 7th year now, but it's about understanding behavior in Huntington's, and it was written by real leaders in the field. And I go back to this, it's very much the foundation. I think there's so much wisdom and so much knowledge here, and I think that Dr. Paulson at University of Iowa really explored these areas and educated all of us about how to understand these difficult issues. Okay, I think I had a little animation there. All right, so cognitive changes, like behavioral changes and mood changes, are among the most disabling parts of Huntington's disease, and cognitive changes, unlike behavioral changes, are inevitable. Everybody with Huntington's will have them. Behavioral changes are much more variable and hard to predict and hard to track. They're not linear. The cognition really is very, very linear, and it starts before diagnosis. For sure, it starts before diagnosis. So if there's one thing to remember from this talk, I'm really focusing a lot myself on early diagnosis, early recognition, having people come in the prodrome, not waiting till you're sure you have HD, but trying to set the stage earlier as we can. And we know that these cognitive changes can have meaningful impacts on people's ability to work and do things at home, but they also affect people's relationships with their families, and the result is stress. The person with HD is having stress, even if you can't see it on their face, it's already there, and the family is reacting to that stress a lot, and it can lead to a lot of conflict. So recognizing it's there and analyzing it and finding ways to cope early, I think, is really the key. So I have a little picture here of a person with a brain. I want to take your attention to the blue box there. So we have all these different types of cognitive abilities, things that we all do that are related to different parts of the brain or different connections or networks within the brain. But in Huntington's disease, it's all about the frontal lobes. And the frontal lobes involve control of our motor abilities, but also executive functions, which you've heard us talk about before, and then also social and emotional behavior. So I think about Huntington's as this area of the brain where we're controlling movement and thinking and behavior, all coming through this circuit deep in the brain, and that's where we end up having these difficulties. So we have a functional rating scale for Huntington's disease. You may have heard about this rating scale. You're at stage 2, you're at stage 1, you're at stage 3. How do we derive this? We derive this by people's functional abilities, not by their brain scan, not by their CAG, repeat length, not by anything hard like that, but by how are you able to do at work and managing finances and taking care of yourself and your home, and where is your living situation. And we have something called the Total Functional Capacity Score, and it starts out very high. People start out life with a Huntington gene expansion, and they're doing absolutely fine, but there are changes happening way early in the brain. They reach a certain threshold, and then we start to see these changes. And we're noticing more and more now that the behavior changes and the cognitive changes come before the motor changes do. So we want to kind of focus on that area, because the sooner we can identify and plan and make accommodations for these things, the better it is for the person. So next is an old slide that I created a long time ago that's listing behavioral symptoms. So I want to show you two things. The yellow tag there's on the striatum. It's a deep structure of the brain that we see. And this slice on the left side is someone who's died of not of Huntington's disease. And that's the normal size of the striatum. If you cross over on the right side, that's somebody who's died with advanced Huntington's, and you see that area of the brain is so shrunken and it's almost gone. And that's the area, that's the targeted main area that we're seeing with Huntington's disease symptoms. The surface of the brain is called the cortex, and there are projections from all parts of the cortex into the striatum and back again. And that part of the brain is also degenerating, and so is the white matter in between. So Huntington hits all of the brain, but the specific symptoms that we see are coming from the changes in the striatum. And I've listed here in green and blue all types of behavioral symptoms that we see with Huntington's disease. And we'll talk about some of them individually here, but it's coming from these circuits, and a person doesn't start out with that degree of atrophy. That's at the end of life, that's at the end of having Huntington's, but the changes have been found up to 20 years before the symptoms start to show up, maybe longer. So keep this in mind. So there's a picture here looking at an MRI brain scan over here on the right, and this is a person with Huntington's disease at age 45 years. In the red box is the striatum, the area of the brain that's targeted. If you look 5 years later, you see that it's shrunken down a lot. Even in 5 years, there's a tremendous visible amount of shrinkage here. And there's a very nice graph from Dr. Paulson's work looking at the size of this area of the brain in people who had the gene expansion before they were diagnosed with Huntington's disease, and looking at those far away from when we think they might start to get symptoms, getting in closer and closer. And if you look at people on the bottom here, 5 years before diagnosis, they've lost already a third to a half of this area of the brain. So it's visible, it's very real, and it doesn't show up on the outside. It's happening internally and with the way the person's feeling, the way the person is behaving. So when does cognitive impairment start? I've given you the answer. Before the motor diagnosis, it starts very early. So when we think about cognitive impairment, we have three baskets. One basket is normal. You don't have any symptoms. You don't have any functional problems. That's people far, far from the time when they might start to get symptoms. But we have a transitional zone there called mild cognitive impairment. And this is an area where people have difficulty with at least one type of thinking skill, whether it's executive function or memory or language, something along those lines. but they're still able to function and get by pretty well. But people with mild cognitive impairment have symptoms. They have difficulties. They can recognize them, the people around them can recognize them. So there's a long transition zone with mild cognitive impairment. And then dementia means impairment in at least two of those domains. So it could be memory and executive function, for instance, and there's a functional decline. And we don't use this word enough in Huntington's, but people with Huntington's get dementia. And dementia is a core feature of Huntington's disease. So this was a very important study, the PREDICT study. I'm just going backwards here a little bit. This was a study that Dr. Poulsen led that enrolled about 1,000 people around North America and also in Australia and Canada at various centers. And these were people who had decided to do the gene test for Huntington's, but they didn't have any symptoms. And for every 6 people who had the gene expansion, they enrolled one person who had tested and didn't have the gene expansion. That was the control group. And in this study, they looked at cognitive test performance in 575 people who were gene positive versus 160 who were gene negative. And far before diagnosis, 40% of them already had mild cognitive impairment. They already had something that was measurable. They didn't have dementia, but there was something already that was going on. And I think that the study was published in 2010, and I don't think we give it enough attention. It took until 2020, 2 years ago actually, before a group that's in Florida looked at the prevalence of cognitive impairment in people who are already diagnosed with Huntington's disease. So this just hasn't been studied enough. We get focused on Korea, we get focused on other things, but we need to pay more attention to this. And at motor onset, 85% of people already had mild cognitive impairment. And 5% of them met the criteria for dementia. And if you go out 5 years, now the mild cognitive impairment has transitioned over to dementia. And again, because of the behavioral symptoms, because of motor symptoms, all these things are going on. There's so many targets, but we don't always identify this, and it can be frustrating, and it can be very, very difficult for our patients. And it's obviously a very important target for treatment in Huntington's. So important symptoms that we see, I wanted to highlight 4 here, that come from loss of executive function, loss of these connections from the frontal lobe into the striatum. I listed all of these. I want to just say something about these top 4. I think these are the main ones that we have to focus on. And so what I wanted to mention with executive function is people, let me go backwards here for a minute. People have difficulty with organization and planning. People have trouble starting things. They have apathy. They just lose their get up and go. They have trouble with the amount of time it takes to do things. They can't transition from one thing to another very easily. They have a whole host of things that are subtle but very, very measurable and very, very real. And there are ways that we help people to deal with those problems. And the first is when you're in the prodrome for Huntington's, or when you start to have symptoms of Huntington's, it's so important to set a routine schedule, to allow plenty of times to do things, to allow others to help you, to use your smartphone or to use Post-it notes or whatever it might be, so that we can help that executive function to be stronger and to be more supportive. And we use calendars and we use reminders, so there's all types of ways that people can do this. And people who have dementia do this. People who have mild cognitive impairment because they might be getting Alzheimer's in a few years can do this. People with traumatic brain injury can do this. Anybody who has an injury to the frontal lobe can benefit from these. So I want to show you what, I hope this animation works, we'll see. I want to show you what I tell people in clinic, okay? How do you make a daily schedule? The person who's prodromal, the person who has Huntington's, this is what you need to do. First, you have to set a wake-up time and a go-to-bed time, okay? And I will give you a hint here. The go-to-bed time has to be before midnight. You can't go to bed tomorrow, okay? Because a lot of people with HD shift into staying up all night long, and I tell them, you cannot do that. You have got to come back, and at least by midnight, if not earlier. And you have to set a wake-up time. You cannot lay in bed. You have to be up with the birds, up with the sun. You have to have something there where you have a schedule. And you, the person with HD, you get to figure this out, okay? What's best for you? But I'm giving you some hints here, okay? The next thing you want to do is put in some meals. You need to be fed, okay? Set a time. Breakfast is at whatever time, lunchtime, dinner time. It's all set up. So that day, you don't have to wake up and say, when am I going to have breakfast? breakfast today. It's already planned. You know what you're going to do. And if you then add other activities to this, maybe in the morning you're doing your exercise routines and some chores, maybe in the afternoon you have some other type of routine that you're doing, and then after dinner you have an evening activity, now you have a schedule. Okay, so I really, really strongly recommend, we should all do this, our brains like this, but this is something that particularly helps people with Huntington's. And again, sometimes you can employ your family members or your friends to kind of help you with this, but one thing you might see, there's not 20 things on this list, okay? So if you plan to do 20 different things every day, you're going to feel like a failure at the end of every day you didn't do that. So what you want to do is make it something that you can actually achieve and actually do. And that's my last point. And then scheduling time for rest or a quiet period, very helpful because the brain needs to replenish too, because we're working on overdrive to compensate. Okay, and now here's my tips for creating a weekly schedule. So depending on where you are, you might have prodromal Huntington's and you're going to work, raising a family, going to soccer. You might be doing a million things. But when I tell people who are a little farther down into their Huntington's diagnosis, just make one activity a day. Start out with, this is what I'm doing on Mondays. This is what I'm doing on Tuesdays. I have some examples here, okay? There's only one thing on here, okay? So you put that schedule in, you have something else here, and if your ability is there, you can build on this and add more. But the more that you have these routines, the better. Let's see here. So it's important to add only as many activities as a person with HD is able to do. Don't overload the schedule. A common problem is a person has mild cognitive impairment, they have to stop working, and they now are at home all the time, and it may be like, oh, you're not working anymore, I have 20 things I need you to do every single day. And so no, you plan for this and you try to make it easy and accessible for that person. And this list should be short and attainable, and it can be longer in the early stages, and it needs to get shorter as disease progresses. Okay, so compensatory strategies, what other things can you do? Minimizing distractions, one thing at a time. If you can try to slow things down and focus, that will help a lot. If you're still working, work in a quiet location. Have your noise canceling headphones on, or don't be in an area where there's lots of distractions. That can be very difficult. And then the person with HD, we have to slow down, and we have to meet them on their own time scale. We have to ask them something and then wait for them to tell us what the answer is. So I have a few more lists here when people are having other issues that you could kind of take a look at. I'll keep moving on here. And I'm going to change over to apathy. So what is apathy? The most common thing that people think is apathy is depression. The person is not able to get up and go. They've lost their drive. They're not able to do things. Remember, that list isn't too long, but a person with apathy, that might be all they can possibly do in a given day. And so apathy is the loss of ability to initiate and carry out activities, but it's not caused because you're sad or you're depressed or you're anxious. It's a brain function. And apathy is the one symptom that we see behaviorally with Huntington's that tracks with the disease progression. The longer you have HD, the worse the apathy will. And the person with HD, remember, they're aware of this. They know that they have apathy, and it's not a good feeling. There's a lot of guilt and a lot of negative feelings that go along with this. And so it's important to recognize that when it's happening and then to employ strategies to help out. And guess what one of those strategies is? That schedule that I told you about. Take it down to something really simple and really easy, and focus and allow a lot of time. Don't try to crowd too many things in. Sometimes we use medications. If the schedule isn't enough to do that, some people have severe apathy, and there are some medications for mood that can be very helpful to help that person activate and be able to improve their functional status. Unawareness in Huntington's disease, a big problem. So again, frontal lobe to the striatum, it tells you your state. It tells you how you're doing. How am I doing? People with HD sometimes can't recognize that they have HD. That's the most severe case, where the person may have very obvious symptoms, but to everyone around them, but they don't know it. They can't sense it. The brain isn't giving them that signal. That's a very, very fragile, delicate problem because there's no way to force this into recognition. We have to use all kinds of strategies to help that person. But just as people can't recognize Huntington's symptoms, they might not recognize that they're being irritable. They might not recognize that they're having difficulty doing things that they used to be able to do well. And sometimes they externalize that. So sometimes a family member's told me that their loved one is being really cranky and really irritable. And then when I ask them how they're feeling, they tell me in front of their partner, oh, my spouse is really driving me crazy. They're so constantly mad all the time. They're so cranky. And I've already heard from them, and that's probably not what's going on. I mean, we can all get cranky, but still, it's a very difficult thing to help the person to understand that they themselves may be having this problem. And so just remember, it's not their fault, it's a disease, and there's some strategies here. It's challenging. So what we do know is confrontation and arguing and insisting on this isn't going to work. It never works, actually. So you have to be persuasive and gentle. You have to be supportive. You have to let the people around that person who has unawareness be aware of that. And you can use creative solutions. And sometimes you can actually just focus on the behavior that you want them to be displaying and figure out some things that will make them happy, give them some rewards. Like if we can get something done that needs to get done, let's go out and take a walk afterwards, or we'll go for a drive, or we'll go drive through and get Starbucks, get you your favorite coffee drink, whatever that would be. But using those types of incentives can sometimes help that person agree. And then the last one is perseveration, getting stuck on certain ideas. So this is a very common symptom that results from this cognitive change. And the person with HD can get stuck on certain ideas. Sometimes it's just one thing, sometimes it's multiple things that they get stuck on. Sometimes people get stuck on that schedule I just showed you. And they maybe let's say their life partner has gotten the flu overnight, they've been up sick all night, and the person with HD will be there at 8 o'clock in the morning and say, where's my breakfast? It's my time for breakfast right now. It's a schedule, and they can get very stuck and very upset if you can't stick to it. So use that schedule, but be aware that sometimes the person with HD can get stuck on that schedule. They can get stuck on things that they're worried about. They can get stuck on other types of activities during the day. And the difference is this is not the same as obsessive compulsive disorder. And why is it not? A person with obsessive compulsive disorder, which sometimes happens in HD, not that commonly, might be very perturbed and worried and concerned about things like germs or contamination or something like that. And it's so bad that they have to wash their hands and wash their hands and wash their hands till they're raw and bleeding, and they can't stop themselves. They're in distress about it. The person with perseveration isn't really upset about it in the same way. Their behavior upsets everybody around them, okay? So they don't think there's anything wrong with this. It makes perfect sense to them, and the people around them are often struggling. So that's the difference. And perseveration is way more common than obsessive compulsive disorder. So I have some examples here of perseveration. I've known people, they've told me that their loved one has called them like multiple times a day on their cell phone. They call and call and call and call. They can't stop using the cell phone. There's just a whole list of things here. Everybody's different. Every human is different, but there can be different types of perseverations. And just to know that these are present is really important. It's not their fault. And strategies, what can you do? You can use reassurance. You can use that schedule and say, actually, breakfast is not at 7:59, it's at 8 o'clock, and I'll have it ready for you in just a minute. You can set limits. You can't really argue people out of this. You have to use kind of a soft touch with this. And we use medications. Medications can be very helpful because sometimes perseveration is coming from a place of anxiety or depression too. So keep that in mind. Let us know if it's happening. Last thing is about memory impairment. There is memory impairment. It's different than what we see with Alzheimer's disease, but it's there. The person with HD has more trouble learning new information, retaining information. So using strategies like reminders and using that very simple schedule that we talked about can help promote memory. There have been some medications that have been tried for memory difficulties in people with HD. We borrowed medicines from Alzheimer's. They're well tolerated. I don't know how much they work. The evidence doesn't show that they help that much, but sometimes we'll try them and people will get a little bit better. And there's new studies of new medications that might be very helpful that we're really crossing our fingers about here. Okay, so communication is the last part. Communication. So the person with HD has changes in their brain that make it hard for them to hear what you're saying, or to process multiple different things all at once. And later in the disease, the longer it goes, the harder and harder this gets. And so communication is such a fundamental part of being human, being a member of a family, and using strategies that help make it easier for the person with HD to communicate are always welcome and always important. And one thing that we do is we early on involve the speech and language therapist to help people to assess them and help to explain what the difficulties might be and to develop a plan. And this has to get updated throughout the course of the disease, how we communicate. Okay, there are a few cognitive assessments that we use for Huntington's disease, and my goal today by putting these up here is to tell your doctors, can I have a mini mental status exam score once a year? Can I have a MOCA test once a year? Can you track how I'm doing with my thinking skills? It's a really important thing to do. We have these research tests that we use also that are done in research studies. If you're part of Enroll HD or other studies, you'll know about them. But the really important one is formal neuropsychological testing done by someone who's trained to do these assessments. And that testing lasts about half a day, at least half a day. It's very comprehensive, and it results in a report that shows by every single domain of thinking how that person's doing. So it's great to get a baseline. If you're gene expanded or at risk, it's great to get a baseline because during the prodrome, these abilities will start to change. Mild cognitive impairment will start to show up, and it can help identify where the person's having difficulties and help to put into place accommodations or adaptations. And this is also very helpful for getting that early diagnosis. If you can show a change in cognition, even when there's not a lot of motor findings, that can help with disability applications. It can help to target therapies earlier and not waiting till it's really late. Okay, the last thing to consider, every person with HD is unique and special or different in other ways. So I just want to say HD is only one part of us. We're all very different and very unique. And one thing to keep in mind is each person will be affected in a different way, and you know them best, you know yourself, hopefully best, and try to employ these ideas around who you are so they really work for you. Things that are working at one stage of Huntington's have to be revisited because it's progressive, so you have to sometimes add or change some things that you're doing. And even when these cognitive impairments take away people's abilities, I've learned this from the community that helping that person to feel valued even though they're disabled, helping that person to have meaning in their life and do the things that are important to them is always, always important. So keep that in mind. Okay, and there's a summary for you. Remember that the cognitive changes are there early and be aware of that. I think that's my main take-home point. And if you know about that, and if you know that behavior changes can happen early and you can seek adaptations and help and maybe medications to help out, you'll take down your own stress and the stress of the family, and you will be able to plan and be ahead of things and help out. And I think it can help people to avoid very, very difficult crises and other situations. And I want to end by thanking the wonderful team that I work with at UC Davis, so Becky and Sadie and Lisa and Mara and Dr. Duffy and the whole team we work with, Mike Sturkin, our physical therapist, but also to thank all of you. I also see Dr. Khandhar standing over there too. I want to thank Dr. Khandhar too. He is working at Kaiser. He's going to talk to you about motor symptoms in just a minute, and he leads an extraordinary Huntington's clinic there, multidisciplinary with another huge team, bigger than our team actually, and he's a really valued colleague. So thank you all, and we're going to have questions later this morning. Thanks.
So that was a great segue because next up we have Dr. Khandhar. He is a movement disorder specialist and the medical director at Kaiser Permanente. He completed a fellowship in Parkinson's disease and movement disorders at UC Davis, San Francisco, or University of California, San Francisco. Dr. Khandhar works with a team of specialists focused on Parkinson's disease, Huntington's disease, essential tremor, and dystonia. He has championed multidisciplinary care using an integrated practice model. Awesome. His team clinic, based in Kaiser, Sacramento, is proud to be designated a partner center of excellence by HDSA in partnership with UC Davis. So welcome, Dr. Khandhar. Thank you for being here today.
Thank you very much. So my name is Dr. Wheelock had mentioned. I'm a movement disorder specialist working at Kaiser Permanente here in Sacramento, and help to lead a group of individuals that help to support our patients living and their families living with Huntington's disease. So it's really nice to actually see a few familiar faces in the room, but also quite a few non-familiar faces in the room. But the way I look at things, that we're all friends in this matter, all hoping for a singular purpose to help get rid of this unfortunate condition. And I feel like I have a little bit of an easier job than Dr. Anderson or Dr. Wheelock because I tend to talk about the things that are a little bit more visible. But before I do so, I kind of want to address the elephant in the room. A lot of you might be wondering why I have this. So let me go ahead and explain it. I wish I had a wonderful story to tell, like I was skydiving or I was skiing or I was skateboarding. The answer is none of those are true. I was simply wrestling with my 17-year-old one evening and realized I'm not 17. So bottom line is that I lost a little pride, I gained a caste, and he gained bragging rights. So what are you gonna do? So that said, let me go ahead and start the conversation here. So first thing I really want to express here is something that Dr. Wheelock has already mentioned, is that when it comes to movement disorders within our HD population, we really have to understand how to recognize some of these symptoms. And the thing that Dr. Wheelock talked about was understanding the fact that in this condition, a very specific thing tends to happen. It happens in a lot of neurological conditions, but it's much more particular in Huntington's disease. And that's a concept of self-unawareness, something that Dr. Wheelock actually spent a little bit of time talking about today. There is a neurological term for it called Esoagnosia. Now, it's a mouthful, I do know that, okay? But maybe y'all can say it over here too so we can be dynamic this morning. Esoagnosia. 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 Even it's a mouthful for me as well. So this is a concept that all of you are familiar with, to where an individual with Huntington's may have a specific involuntary movement or a specific behavioral symptom that they don't recognize in themselves, but their loved ones do, their providers do. And oftentimes, even when challenged about, hey, you're having these involuntary movements, they themselves go, which movements? It's not uncommon for you to be sitting in the office, or for me to be sitting in the office and say, well, you seem to be having a little more chorea today than when I remember last seeing you. And they're sitting there doing this, going, what chorea? I'm sure you have all recognized that to some degree. So this is a very, very common thing that we see in Huntington's. It also becomes a little challenging for the provider and the loved ones, because then you try to address it, and yet they're trying to push back on trying to increase their treatment or advance their treatment. So my sort of strategy to this is really to help patients and their loved ones understand that they need to trust their team. Whether that team be their family or that team be their providers, trust your team and understand that they're trying to help you. They're trying to identify what it is that's limiting you so that you can do better. Because our ultimate goal is to help people live with Huntington's better than they were otherwise, to help keep them independent. And the thing is that, the interesting thing is all three of us here are going to be speaking today about different columns of symptoms that people express with Huntington's disease, whether it be behavioral changes, cognitive changes, movement changes, right? But the reality is these all overlap. You treat one, you might ultimately partially treat another. It's not that, oh, you're only having behavioral issues, you're only having movement issues. All of these things overlap. And so if we can help to treat one really well, then maybe the other two tend to follow suit. So in that respect, I usually recommend that people do their best to empower themselves. And that comes from a few things. And those things are really going to be education, which is what we do a lot in Huntington's Clinic. I probably spend a lot more time talking to my patients than I am doing examining them. Now, we're not a research center when it comes to Huntington's and Kaiser. This is why we're in partnership with UC Davis, because they're the research gurus. They're the ones that are basically putting out the new treatments and the new understandings of what's going to happen for Huntington's in the future. So our job really is to identify what is it that you're expressing, what is it that you're having, what you're experiencing, but also to educate on what that means for them. All right, so let's talk a little bit about chorea. So what is chorea? We heard this term a lot. Chorea, basically, if you look at the etymology of the word, it comes, it's sort of shortened for choreography, to dance. It's a Greek term, it's a verb, right? But these are these involuntary movements that we see a lot of our members with Huntington's have. So you're going to have these sort of random, writhing sort of movements that occur from one segment of the body to another segment of the body. They can happen in the face, it can happen in the arm, it can happen in the trunk, it can happen in the legs. And this is probably the most important involuntary movement that's identified in Huntington's. It's not the only one, though. And so the thing with chorea is that people initially, when they start having it, even though they may not recognize they're having it, they start doing what's called quasi-purposeful movements. They'll start doing another movement to make it look like that movement was meant to be, right? So I'm going to give you a couple of examples that may not necessarily be Huntington's, but you all saw probably last couple of seasons of Spin City with Michael J. Fox, right? Michael J. Fox has Parkinson's disease, but he'd have some involuntary movements to where he would end up pocketing his hand, right? Most every episode in the last season, his hand is in his pocket. Why? Because he's making it look like that's what it meant to be. Or somebody has involuntary movements to where they do this and they put their hand behind their back. Something that makes it look like the movement is meant to be, because our brain is trying to reconcile the fact that I'm having these movements and I don't want to look like this in front of public. So therefore the brain's going to try to change things to make it look like that movement is meant to be. Again, I usually use that a lot to express to some patients that, look, you're having the chorea, even if you don't recognize you're having the chorea, but you're making these other movements in order to try to reconcile that chorea. So this is something that we can actually treat, not just the quasi-purposeful movements, but the actual chorea. There are medications that are FDA approved, some that we use off-label for help in these movements. So one, you guys have probably heard about Tetrabenzine, right? Or tetrabenazine sister, deutetrabenazine. These are medications we often prescribe for chorea, and they work very well. There's always going to be a little bit of titration to the medication because the medication has some potential depressive side effects. So if somebody already is quite depressed, these may not be the medications to consider, but they are wonderful medications when it comes to suppressing chorea. Usually we dose these medications twice or 3 times per day. Regular tetrabenazine usually is 3 times a day. Deutetrabenazine sometimes given twice a day. And the side effect profile for the two are very, very similar. There is a third class of medications that we sometimes will prescribe in the absence of tetrabenazine, particularly if somebody actually is having a little bit of depression and you don't want to give the tetrabenazine. And that would be the class of medications called antipsychotics. And this is commonly done in a lot of centers for Huntington's disease. One particular medication is a medication called Olanzapine. It's one that I learned from Dr. Wheelock. Is that medication being an antipsychotic, even though if you look at the label, it says for schizophrenics, we're not using it at high level doses, we're using it at more mild to moderate doses to help suppress chorea. But at the same time, we're also looking at it for its side effect profile too. These medications tend to be given once a day. They tend to be sedative. A lot of patients with Huntington's have a hard time falling asleep and staying asleep. So maybe a side effect of being causing it to be a little sleepy is not such a unwelcome side effect. It also can cause mood stability. So therefore, if you give it to a patient who's otherwise aggressive or impulsive or a little irritable, it's a good medication to have on board. And many of our patients with Huntington's disease over time will lose a little bit of weight. And so by adding an antipsychotic, you're going to be able to cause them to have a little bit more hunger, a little bit less satiety easily. So therefore, you're going to actually invoke a little bit more weight gain on the medication. Not such a bad thing with some of our patients. So for me, going and moving towards using an antipsychotic is not unreasonable, and we do it actually quite commonly. Any questions on chorea, or what chorea actually is? A lot of times patients ask me like, well, how do you describe chorea other than what you wrote up here? How many of you guys have seen the movie Pirates of the Caribbean? Right? Yep. So Captain Jack Sparrow, right? He looks like he's a bit animated, right? He's got movements like this and like that. Those are the movements that I try to explain to children of those who have Huntington's disease. That's chorea. And he did a beautiful job expressing that in the movies. I don't know how he did that, but he did pretty well. All right, dystonia. So what is dystonia? Dystonia is a sustained muscle contraction that causes abnormal posturing and positioning. And there are certain forms of dystonia that's, common. And there are certain forms of dystonia that are not so common. So a common dystonia would be something like a writer's cramp. So somebody, back in the day when we used to actually write things and not type things, sometimes your hand would kind of turn inward and get stuck in that position to where you get a lot of pain or a lot of tension along your forearm. That's a writer's cramp. It's a form of focal dystonia that occurs only in the arm or only in the hand, particularly when performing a certain task. Then there's things that can happen because of musicians' over and repetitive use of certain muscle groups. So people can, like pianists, can have a focal dystonia of the fingers when they're trying to play. Or a trumpeter can have focal dystonia of the mouth when they're trying to purse their lips. Or you're going to have somebody who's like a violinist who is sitting there doing this all day long, and even when they're not violining, their neck will actually move in that direction. That we call a cervical dystonia. Sometimes dystonia can be quite common in Huntington's disease, and there's specific treatments for it as long as it's recognized. Oftentimes we'll use things like muscle relaxants. But the most common treatment that we use is the application of botulinum toxin. So this is where you inject botulinum toxin, which is a focal neuromuscular blocker. It basically inhibits the transmission between nerve and muscle. Right? Nerve tells muscle what to do. If nerve over tells the muscle what to do, that muscle will contract. If that muscle contracts, it's going to cause a lot of pulling, a lot of strain, even some pain. And therefore, injecting the muscles that seem to be overactive can relax those muscles, giving people better quality of life. Something so simple, as long as it's identified. Right? So that makes sense about dystonia? Okay. Tics. Now we hear about tics because we associate it with things like Tourette's. A tic is a quick, sudden, random movement that can be repeated or stereotyped many times over. So a tic can happen in young children just for normal reasons. But tics can also happen in Huntington's as well as things start to advance. And tics might be something as simple as eye blinking or a little throat clearing or a little shrugging of the shoulders. But these kind of things can be social hinders, right? So somebody who's ticking away with their face or with their arms, you add that to a little bit of chorea that they're already expressing, and then a little bit of dystonia that they're already expressing, and people start to feel that there's no way that I want to be seen in public with this. It's really distracting to people. And if you think about it, if you're having this many distractions from a motor standpoint, you are not going to be able to focus your attention on what it is that you're talking to that person about. So cognitively now, you're also going to be impacted as well. Behaviorally, you're going to be impacted because it's going to annoy you. It's going to irritate you, right? All the things that we talked about this morning now. So identifying, again, tics, somebody having those kind of movements, are there things that we can do about these tics? And the answer is yes. Behaviorally, there's quite a bit you can do for tics. And this is the stuff that we do with our young folks with Tourette syndrome, is behavioral techniques, sort of mental relaxation. These kind of things can help to suppress tics. Tics are one of the only movement disorders that can be suppressed. But if you try to over-suppress it, then what happens is you build up a lot of angst and anxiety, and then like a volcano, you're going to have far more tics that occur later. This is exactly what happens in Tourette's. It can also happen in Huntington's as well. So finding the right balance between what muscle relaxants someone might need to be on that's not too sedative, or botulinum toxin that might need to be delivered for dystonia, or a little bit of Zyprexa or Olanzapine that might need to be delivered for that chorea, and then adding some of these mental relaxation techniques on top of that in order to help overall reduce the angst and anxiety that tend to accompany some of these things. Now, one thing you're not going to see up there with other hyperkinetic movements that we do not commonly see in Huntington's disease is tremor. How often do you guys see tremor with Huntington's? Hardly ever, right? So tremor is a rhythmic movement that occurs at the level of a joint. Think Parkinson's disease, Muhammad Ali, 1996 Olympics when he lit the torch at the Atlanta Games. Right? Rhythmic movement that happens at the level of the wrist. It could happen elsewhere in the body, particularly in the limbs. We usually don't see those kind of rhythmic movements in Huntington's disease. We see more sustained movements. We see more sudden movements. We see more random movements. And it really does take a trained eye to be able to recognize these things and then understand what that might mean for them, but also look at the array of treatments that actually could help those particular movements. So, moving on. I kind of want to spend a quick moment talking about imbalance, okay, and talking about ataxia. Ataxia basically is just a fancy neurological term that means incoordination. So imagine if you were ever, I don't know if you guys ever did this, if you ever were in the Northeast during the winter months and decided that you wanted to go walk on ice. We don't have so much of that here in Northern California, or where I grew up in Southern California for that matter. But if you think about what you'd have to do to maintain your balance to walk on ice, you'd have to spread your feet apart. You'd have to spread your arms out to try to make sure that you kept your balance, like a tightrope person would do with their arms pressed apart. But on ice, you have to keep your feet spread apart as well. So think about the type of walking or the behaviors you'd have while walking in order to maintain balance. That's called ataxia. The inability to coordinate the next step or the next movement. This is not uncommon in Huntington's as things start to progress. Those people who also have a lot of chorea will start to express difficulties with walking, right? Making it very challenging for them to get out of the house, go for that walk, participate in exercise, or even come to your doctor's appointments. And then there's instability. The ability to be able to maintain your posture when you're standing. Right now, here I am standing at 1 foot back, 1 foot forward. If I were to press upon my back, those paraspinal muscles, those muscles that are just flanking the spine, they're active. They're working hard to keep me upright. Well, sometimes that type of instability is going to be there in Huntington's to where they can't do that. I saw a person with Huntington's just about 2 weeks ago who had to keep their bent posture forward in order to keep themselves upright, because if they tried to stand up straight, they would fall backwards. So this is where walkers come in. This is where walking sticks come in. This is where things like assisted devices come in. And often I tell patients that if you're going to need to use an assisted device, use the least restrictive one. So often people will think, oh, I'm going to use a cane. Well, I'm not a big fan of canes. Why? Because canes basically force you forward, right? So you look like you're a lot older than you actually are. And for me personally, I would have a hard time with it myself. I can imagine my patients that have a hard time with it. On the other hand, maybe 2 walking sticks. Now you look like an avid hiker. But it also keeps you going, keeps you upright, keeps you actually doing things. And then walkers. If you just Google search walkers, you're going to get 1,000,001 different types of walkers. Well, there's certain specific types that might be better for some patients than others. Is it a front wheel walker? Is it a large front wheel walker? Is it a 4-wheel walker? One with the seat, one without a seat, one with brakes, one with reverse brakes, one without brakes. So there's all these various types of walkers out there, and it takes a very good physical therapist to understand what are your incoordination issues, what's your fall risk, and what assisted device actually makes a lot of sense for you. So now we get to, if you recognize your symptoms, that I'm having chorea, and I'm having a little bit of dystonia, once in a while I may tick away, and my balance is really bad, then you can start to create a program that makes most sense for you to maintain your independence. Allows you to do things that you otherwise enjoy doing. Because the worst thing that can happen to any patient, whether you're someone living with Parkinson's, a care partner caring for somebody with Parkinson's, for Huntington's, or somebody with any other movement disorder for that matter, is to stay restricted. To limit yourselves to be able to do things. And so for me, at least in our network, I love the idea and this concept. I'm tickled by it, that what can I do, or what can my team do to help you live better? Get out and do things and enjoy the things you enjoy to do. So for me, that really does take a multidisciplinary team. It might involve some medications, it might involve some therapy, but whatever it takes to get you doing the things you enjoy to do. So for that, we really do require, a multidisciplinary clinic. And so in a multidisciplinary clinic of any kind that's a Huntington Disease Center of Excellence as designated by HDSA, there are 2 things that are absolutely required. You need the neurologist, who actually understands a little bit about Huntington's disease. And to let you all know, most neurologists who've gone through general neurology residencies, they don't see a lot of Huntington's in their residency. It's a 3-year residency after doing a 1 year of internal medicine sort of transitional year. But in my residency, I think I saw 2 patients with Huntington's in all 3 years, because most of the time it's an inpatient residency, seeing a lot of stroke and seeing a lot of meningitis and headaches and things like that, but not outpatient Huntington's problems or problems with movement disorders. So you really don't get that Huntington's understanding until you do a fellowship training, or you learn on the job to where now you're leading a Huntington's program. So I think that seeing a movement disorder neurologist, someone who actually understands and appreciates movement disorders or Huntington's disease, is actually quite critical. A social worker, we have Lisa here somewhere? Maybe she was? Okay. Or our social workers at Kaiser, or I'm sure at the social workers at Georgetown, they are probably the heart and soul of the whole clinic. Without them, it's really hard to understand how you can live well with Huntington's. So I really want to put a shout out to our social workers. Maybe they're not in this room, but hopefully they can hear me. Other things, genetics and genetic counseling. You can't actually have a good multidisciplinary clinic without having that genetic and genetic counselors, right? So for us, at least at Kaiser, we have Mara. I don't know if Mara's here. She was here before, but Mara luckily works both for us and at UC Davis. It's a really wonderful partnership, but that understanding of the genetics behind Huntington's, that inheritance risk, what that might mean for the rest of the family, because this really is a family affair, is going to be critical. Psychiatry and mental health services, as we heard about earlier today, so important. Make no mistake, this is a degenerative disease, but it's also a neuropsychiatric one. And so just treating the movement piece of it is not going to be enough. You're going to need to be able to understand what other, sort of behavioral issues are plaguing that individual, and you're going to need a very good psychiatrist to be able to navigate that. Physical therapy. We just talked a little bit about the need for a physical therapist who understands not just assistive devices and gait and fall risk, but also understands how we can help improve range of motion. Sometimes these movements, as much as they look animated, they are still quite restricting. And so people can start developing contractures and pain and a little bit of tightness in some of those areas. But a good physical therapy session to understand how you can stretch, how you should exercise in between those sessions at home can be critical. Palliative care, understanding how we can live well with this, whether it be through all of these providers working together in unison, or whether it be through palliative care services. I know that at least our organization, as well as at UC Davis, I'm sure at Georgetown as well, all of these organizations have palliative care services to where we understand what is it that we want as things move forward. How do we want to write and author our own book? Okay? So think about, sometimes these are tough questions, and they're tough questions that we sometimes don't want to face. But how do you want to author your book? And that's where palliative care comes in. And then last, study coordinators. We don't have them at Kaiser, but at UC Davis, at Georgetown, absolutely. And why is that important? It's important because without you, there is no research. Without you, there's no advancing treatment. And so having study coordinators to help folks navigate whether a specific study is right for them, whether they meet eligibility criteria, and whether they have the capacity to participate and give informed consent. This is what study coordinators do, and they are amazingly critical to the future of Huntington's care. So the concepts behind a strong movement disorder or multidisciplinary clinic for Huntington's disease is the fact that you're on the right meds, you have the right therapy, and you certainly have the right education. Leveraging telehealth. Probably more than any other time in the history of medicine, we have understood the value of telehealth in the last couple of years. I mean, if there's any silver lining to this pandemic, it's the fact that we've been able to leverage the use of it. And not just we in the medical world knew that there was some value to it, but there were limitations. And those limitations being things as simple as reimbursement. You could not get reimbursed for something like a video visit, but now we can. Medicare services have opened up to that. So if you live far from where your providers are, leverage video visits, televisits. It's a way in which you can connect to your medical community, your medical team. Now, it's like we talked about some of the barriers there. And, that's it, I guess. Right. So what I really want to do is give you guys a little bit of an overview of what are some of the movements that people can have with Huntington's disease, how we can identify them, how we can possibly treat them. And just to kind of take home point is if you treat the movements well, then you can focus your attention on treating the other two columns of issues that people tend to have. They often overlap, they often connect, and the personality, i.e. phenotype, that somebody expresses with their Huntington's disease is different from individual to individual.